I'm Paul Billings. I'm the Chief Medical Officer of Life Technologies. I'm moderating this panel, which is on the detection and prognosis. And we're going to have 4 brief talks and then an open discussion immediately afterwards to answer your questions and take your comments. Just as a brief introduction to the panel, I just wanted to say that platforms matter. And that science has moved ahead by improved measurements. There are plenty of examples of that, and we're going to hear actually 4 talks in which the platforms have illuminated new areas of science and medicine to the benefit of patients. But one clear example of how platforms matter is in genomic analysis. We've invested over the last 20 years a great deal of money in genomic analysis, both at the federal level and in the biotech sector, and the impacts have been profound. A Battelle study recently showed, and this Battelle study was partly supported by Life Technologies, that the economic gains from the Human Genome Project have been profound and in the billions and billions of dollars. Other quantitative measurements of the impact of improved measurement of genomic variation are illustrated in this slide. And you just have to go down this slide to see that we've gone from very few human genome sequences to thousands to tens of millions of SNPs and to many, many disease variants identified when none were known early on. When this kind of powerful platform is mixed with this increase in productivity, the potential for transformative basic, translational, and clinical applications are available. This kind of phenomena allows us to do genetic testing and genomic testing that payers may even pay for on a very large group of people. And what is the result? Well, the result is, as we've talked about already this morning a couple of times, the transformation of taxonomies and nosologies from a very old, antiquated system of anatomic pathology into a new one driven by very fine mutational analysis of disease. And I think we're going to hear a lot of examples of this kind of transformative kinds of applications in the talks we're about to hear. The first talk is from Victor Velculescu, who is the co-director of the Cancer Biology Program and professor of oncology at Johns Hopkins University. We have, by the way, lots of representations of Johns Hopkins on this panel. He's internationally known for his discoveries in human cancer. He's done wonderful work in sequencing, in expression, in digital karyotyping, and recently in the PAIR, which is the personalized analysis of rearranged ends analysis of cancers. He's a member of the board of directors of AACR and has won numerous awards, and he's going to talk about mutational analysis in cancers.
Thank you, Paul, and thanks to the organizers for inviting me. I wanted to share with you today some of our experiences from cancer genome analyses and how these now apply to diagnostics. I wanted to first disclose that I'm a founder of Personal Genome Diagnostics, and some of the work I'll be describing today has been licensed to various organizations. So the work that I've been involved in really began a number of years ago, back in about 2005, with the comprehensive analysis of genomes in a variety of tumor types, starting with colorectal, breast, pancreatic, GBM, medulloblastoma, pancreatic neuroendocrine tumors, ovarian clear cell carcinoma, and head and neck cancers. And these types of analyses really opened up for the first time the genome landscape of human cancer. It provided us with new drivers, new targets of potential therapeutic interventions, some of which are listed here. But I think they've also opened up a new way of thinking in this field, because we're now able to go from the concept of cancer genetics as a research entity through new technologies to really thinking about this in a very personalized sort of way, in a way to individualize these types of analyses such that they're no longer at the bench, but really can apply to individual patients. And this really has been a paradigm shift because it allows us to think about doing this really for every patient that can come through the door. I think this is going to be necessary as we look into the future because cancers really have a very deep level of complexity at the genomic level. This is an example of the landscape of colorectal cancers, and you see here in the top left corner of this green plane the first gene on chromosome 1, and then in the bottom right the last gene on chromosome X, and on this green plane are listed the individual mutations. White as passenger mutation, I'm sorry, if they're in green they're passenger mutations, if they're in these red hills or mountains they're drivers. And you can see placed on this plane two individual tumor genome analyses, where the white is from one individual and the yellow is from another. And what's striking about this is there are only 3 genes that have common mutations between these two individuals. That really shows you the depth of complexity and differences between individual tumors. Just like everybody in this room is different at the genetic level in their germline, no two tumors, essentially no two tumors that have probably ever been analyzed and that have existed in the history of humankind have ever really been the same at the genomic level. And I think it's this underlying genetic complexity that reflects what clinicians have told us for a very long time, which is you might have 2 patients, they might be the same age, they might come into the clinic with the same type of tumor, same part of the body, under the microscope they might look the same, but really when it comes to treating these patients, they behave very differently. One may respond to therapy while another does not. And so out of this complexity, we have to think about how we can actually exploit these genetic alterations. And we already know we can do this for individual genes as prognostic markers, indicators of predisposition to disease, as new therapeutic targets, as modulators of therapeutic efficacy, and as diagnostic markers. And so I think what we need to think about now is how do we transition from individual genes which have allowed us to interact and intervene in cancer in these ways to now doing this in a more comprehensive way, looking at the multitude of alterations in human cancer. And to put this in perspective, I wanted to share with you a case report. And this is a story of a 61-year-old gentleman with pancreatic cancer that was initially treated with gemcitabine, and in parallel his tumor was sent to be analyzed by whole exome sequencing. And of the 85 changes in the exome of this individual, one of them occurred in a gene called PALB2. And in this case, one mutation occurred in the tumor, and another one was actually inherited in the germline of this individual. The 2 mutations together existed only in the tumor. And it's known that mutations in the BRCA pathway, where PALB2 is involved, have been reported to sensitize patients to treatments with DNA-damaging agents such as cisplatin and mitomycin C. So partly based on this information and other information, Dr. Manuel Hidalgo, who did this study, decided to place this patient on mitomycin C. And what you can see here is very dramatic effects during the course of the patient's therapy to mitomycin C, as opposed to his initial treatment with gemcitabine. The patient lived to 7 years, and during most of that time had really excellent performance status and was asymptomatic. This is really a remarkable story. In pancreatic cancer, the average survival is about a year, and there's really nothing that can be done other than standard therapy. So I think this is illustrative of what you can find when you look for the needle in the haystack. And I think it's important to keep thinking about difficult tumors in this way. And recent work by Dr. Hidalgo and others through the Stand Up to Cancer have begun to show that there's actually a much larger number of clinically actionable alterations in pancreatic cancer than has ever previously been considered. But this is a case report, it's an anecdote, and you've heard some anecdotes and case series this morning as well. I think the question is, how do we actually move this to the clinic? And one way to do that is to begin thinking about, again, doing this in a more comprehensive way. And so we can think about doing this through whole exome analyses or targeted analyses where we look at several hundred genes. We really need to do deep sequencing. When you think of germline sequencing, you can do 30x or maybe 60x. When you think of tumors, you got to get down to several hundred or 1,000-fold sequence coverage, or else you're going to miss these rare mutations that occur in impure tumor samples. You have to consider both tumor-specific as well as germline cases. You have to make sure there's a way to do this that's really robust from beginning to end, and you have to do this really on all sorts of different tumor samples. I think detecting the mutations in a very sensitive and specific way is obviously crucial to all these tests. We heard questions before about sensitivity and specificity, and I think that's crucial really in any diagnostic setting. But even when you get these alterations, and let's say you do this comprehensively and very well, you have to know what to do with them. And so first, I think, comes the question of, can you identify driver genes? And so there's a whole lot of literature now on how one can do that and methods, and obviously this is crucial. But even more important than that is linking these genetic alterations to the actual, not only the biology, but to clinical aspects of patient care. So therapeutic predictive information, prognostic, diagnostic, and ongoing clinical trials. And I think what's important here is to recognize that this link between mutations and clinical information is something that's evolving and has different levels of evidence. So some mutations, like mutations in codons 12 and 13 of KRAS, are really so well established from prospective clinical trials that almost any clinician will know what to do with them in colorectal cancer and other tumor types. But there are a lot of data out there from retrospective studies, case reports. I've just told you about PALB2. You heard about TSC1 this morning. In vitro evidence with commonly known genes or theoretical association. Here's a gene IDH2, which is in the same family as IDH1. It probably gives you improved prognosis to GBM, but there's really just too few cases to know. So we have to consider all these levels of evidence, and we have to really keep track of this as this information evolves. If you take this kind of information and look at it from an individual's point of view, and you consider all the levels of evidence, we find in preliminary studies that about 70% of individuals will benefit in some prognostic or predictive way in terms of an actionable change that's present within their tumors. Of course, 100% of analyses will give you some insight into cancer biology. And what's important here is that you'll end up getting a lot more information from doing a comprehensive analysis than you would if you were to just look at some lists of key mutations, which is the way that I think not too long ago, this is how these analyses were done. Now that said, this is a sort of the optimistic perspective. We're gaining a lot of information from every patient by doing these kind of comprehensive analyses. I think we also have to be realistic. And some of these here changed fonts on this computer, but I just wanted to list out the limitations of these types of analyses. And that is that most genetic changes are actually currently not actionable. We need to remember that. Most of the somatic mutations that are out there, actually there's nothing that can be done about them. Additionally, most of the actionable alterations of all the different levels of evidence I showed you really have very limited evidence. They have weak evidence that they're actually actionable in some way. Many mutations occur in actionable genes, but where the mutations themselves have unknown significance. Examples are common mutations in KRAS 61 and 146. There haven't been large-scale studies that have shown what those do. Then there are actionable mutations, but in tumors not previously evaluated, and HER2 new amplification in colorectal and other tumor types are some examples. Other limitations are that cancer genomes may actually change during the course of therapy. We have to think about not only the initial analysis of the tumor, but this analysis over time. And finally, we have to consider just the very basic point that although things may be actionable, there's actually very limited evidence to date that this actionability, if applied and investigated, actually improves the overall survival of patients. So we really have a lot of work to do. And because of that, I think it's important to recognize these types of analyses right now have their most important use really in research, in clinical research, and beginning perhaps of analyses for patient care. And I think you'll begin to see these cancer exome and targeted analyses for phase 1-2 trials, and it'll allow us to discover alterations related to therapeutic sensitivity and resistance, prognosis, and other clinical and pathologic characteristics. You'll begin to see targeted analyses for validation of alterations occurring in phase 3 clinical trials. And finally, you'll begin to also see targeted and exome analyses for interventional clinical trials, like you heard about this morning, and select patient care. What's very important is to keep track of all this information and to try to make use of it. And for this reason, at Hopkins, but in other places, we've established Cancer Genome Registry as a way to connect this kind of information from individual patients from their genomes with their clinical outcomes in order to figure out over time how to make use of this information in the best possible way. So I think we're at a point now where we're really in a transition phase between the existing, let's say, historical genomic methods and new methods that are now becoming available. This transition is now allowing us to go from single genes to groups of genes to whole exome to whole genome analyses. It's allowing us to think of not only there being a few genes that are important in cancer, but really to entire landscapes of genomic complexity, and using that complexity in a way to help patients ultimately. We have to think about mutations as not being something static, but really something dynamic, and you'll hear about that, I think, in the next talk. We're moving from basic discovery to really clinical genomic discovery through, I think, these clinical trials that you're hearing about. And we're also now moving from anecdotes, and I think in the future, we really have to move to genome-based population analyses. And we have to consider going from actionability to improved outcomes. And finally, what's not on the slide here is moving from this type of research in genomics, but ultimately to a way to integrate this into the everyday care of patients. I think we're not there yet, but we can see the light at the end of the tunnel. We understand the challenges and opportunities, and I think it'll be exciting to get there. I wanted to recognize the individuals that have made this work possible, colleagues from Hopkins, from other institutions, alumni, and colleagues from Personal Genome Diagnostics. Thanks very much.
Thank you, Victor. The next talk is from one of the people pictured in that slide. Dr. Diaz is a member of the Johns Hopkins oncology faculty. He has an undergraduate and medical degrees from University of Michigan and did his training at Hopkins. He's been most recently involved in using these methods in translational studies, including creating something which is called a molecular pap smear, looking for DNA fragments in complex solutions, and I think he's going to tell us a little bit about that work. Luis.
Thanks, Paul, and thanks to the organizers of this meeting for the invitation. So when I began my research career, one of my focuses was how do I use somatic cancer information for clinical applicability? And I think a lot of the work had been, exciting work was on predictive biomarkers and prognostic biomarkers. But you had to have a drug and you had to have the right mutation. And the time for that to evolve was years, maybe decades, at least in the hands of one person's lab. And so was there another way to use this valuable genomic information? And one of the ways we thought about was immune antigens. I won't talk about that here, but I will talk about using these as diagnostic tools. And cancer mutations, somatic cancer mutations, are very effective diagnostic tools, and I'm going to list 3 reasons. One is because of biologic specificity. These mutations, somatic cancer mutations, are defined by being present in the precancerous tissue or in the cancer tissue and not in the normal tissue, given very, very high levels of specificity. And that's very valuable in a biomarker where false positives can lead to erroneous clinical actions. Number 2, cancer mutations or DNA with cancer mutations in them, or CTCs, are emitted into ambient peritumoral fluid. That can be into the circulation, or that can be into fluid around the tumor. Those also carry genomic mutations. The problem is when cells secrete CTCs or fragments of DNA into the circulation, or they undergo apoptosis and release these fragments in the ambient fluid, or they necrose and release these fragments in the ambient fluid, it's very rare. The presence of these is at very minute levels. So there was a third component required to make cancer mutations an effective diagnostic tool, and that was new technology. Technology to detect rare mutations in complex liquids or combinations of DNA. And initially we had Sanger sequencing, which its limit of sensitivity was about 10%. Prior sequencing real-time PCR began to introduce errors about 1% per cycle, and those error rates were too high to detect rare genomic events. Digital genomic technology has really revolutionized that. Approaches like beaming, TAMseq, SafeSeq, or digital PCR really allowed us to look at rare mutations in complex mixtures of DNA. And I'll show you why that's important in some clinical samples. And I'm going to use circulating tumor DNA as that example. So the model that we began with to study circulating tumor DNA in these complex fluids was drawing blood from a patient with cancer, taking their tumor, sequencing it for the hotspots or known mutations in that tumor, and then creating a digital genomic approach to look for these mutations in the circulation. In this example that I'm going to use, we use beaming, which is a droplet-based methodology using digital PCR to look for rare variants in complex mixtures of DNA. And the output is sort of like this. So in the upper left-hand corner, you have the wild-type DNA. The bottom right-hand corner in the red, you have the mutant DNA. And this is a patient before potentially curative surgery. This patient had a mutation in APC in their tumor. We beamed or we interrogated the plasma, the circulation for that mutation, and you can see there in the red, it's about 13.4% of the mutant fragments in the circulation. 1 day after surgery, again, you look at the same quadrant, you see a significant decrease in the amount of circulating tumor DNA for this patient, or mutant DNA for this patient. But you still see a few fragments there. Day 42, the patient goes back to the doctor. They get a CT scan. CT scan is completely negative. We drew blood. We see an increase in the amount of circulating tumor DNA at that point. And at day 244, after surgery, we see a significant increase in circulating tumor DNA, and at that point, the CT scan is positive. So kind of giving you a feeling that this circulating tumor DNA, if you find the mutation in the tumor, check for it in the circulation can act almost like an HIV viral load, something that we can track over time that tells us about the dynamics of the patient. But we wanted to see if we could answer some unmet clinical needs, clinical questions that can't be answered by current methodologies. This could be monitored also by a protein biomarker potentially, or a CT scan. Is there a different question that we could answer using these mutations? Well, one of them was minimal residual disease. And as a practicing oncologist, one of the frustrating things is when a patient comes to me after a surgeon has resected the tumor, and the surgeon says, "Oh, you're cured." I know very well that the patient doesn't know. We don't know, the surgeon doesn't know. The only thing that's going to tell us is time, whether the patient's going to recur or not. Is there a way to employ this technology to differentiate with who's cured and who's not cured? And what we did was a similar approach. We took patients who were undergoing curative surgery, surgery with curative intent. Following the surgery, a large fraction would recur and another fraction would be cured. And we used colon cancer, patients with metastatic colon cancer. These patients, when they undergo surgery, 80% of them recur, about 20% are cured. We took their tumors after resection, sequenced them, found a hotspot mutation, and created a specific circulating tumor DNA assay for their exact mutation, so a personalized biomarker. And then we drew blood 1 day after surgery, 1 week after surgery, and 6 to 8 weeks after surgery. You normally have to make a decision about 6 weeks after surgery whether or not you're going to start chemotherapy after surgery or not to minimize the risk of recurrence. When we looked at that time point and interrogated for the mutation found in the tumor that was resected, the bottom line here shows, the dashed line shows, those that had detectable circulating tumor DNA in their blood after surgery, 6 to 8 weeks after surgery. They all recurred. Whereas those that had undetectable levels 6 to 8 weeks after surgery did not recur. So suggesting to us that this could be a very sensitive way to answer that question, that tough clinical question is, am I cured or am I not cured? Should I receive postoperative chemotherapy or not? And the problem currently is everyone gets the postoperative therapy, even the patients that are cured and the patients who are not cured. As physicians, we have no idea who's cured and who's not cured. Hopefully, this can be used to segregate those patients in the proper population. Secondarily, when we take this approach and we treat all patients with the same chemotherapy, those who actually have a high risk for recurring are probably being treated with a diluted form of chemotherapy, and they should probably be dose intensified. If this were practiced in the future, one could envision that those with detectable circulating tumor DNA would be treated aggressively, whereas those with undetectable levels would be treated with a different paradigm. Another approach, again, borrowing the analogy from infectious diseases, is tracking resistance. One of the successes in infectious diseases is that we can actually draw blood cultures and we can track resistance over time. And this is an example where we were tracking the evolution of potentially resistant mutations in patients with colon cancer treated with an EGFR blocking antibody. And these patients were all wild type for KRAS. They were treated with a single agent anti-EGFR antibody. And you can see from the bottom figure here, by the CEA biomarker. This is a protein biomarker. They responded for some period and then recurred. Over time, when we measured a variety of different mutations, and this is an example where we measured KRAS, we see the evolution, the emergence of resistance mutations. Now, we know that KRAS is involved in primary resistance to EGFR blockade, but what we showed here was that KRAS was involved in secondary resistance to EGFR blockade. But what's interesting here is that it's just not one mutation in KRAS, but it's several. It's heterogeneous resistance, which is a little bit scary. Because when we started looking at other areas of potential resistance, we found mutations not just in KRAS, but in NRAS and in BRAF and in EGFR, even within the same patient, which sets up a scary picture clinically. A patient who we think is homogeneously KRAS wild type becomes not only KRAS mutant, but NRAS mutant, MET-amplified, and EGFR mutant. Now, this is a simplified version, but it's a very heterogeneous mix of patient in terms of their genetics. How do you treat that patient? Do you treat them with a MET inhibitor? Do you treat them with something that targets NRAS or EGFR? It begs the question about how we should be treating them prior to therapy with a single targeted agent. Should we only be treated with multiple agents? And then finally, and I think one of the most promising areas of using mutations as biomarkers is for early detection. We all know that once the patient's metastatic, the chances for success and cure are very low, oftentimes less than 5%. If we can catch cancers when they're very early, stage 1, 2 in disease, we can potentially surgically resect them and the cure rates are much higher. One approach that we began to explore about 1.5 years ago was looking to see if we could use other bodily fluids to detect rare mutations and detect cancer at an early stage. And the approach that I'm describing here is one where we hypothesized that ovarian cancers, cancer cells would be released from the ovary, traverse through the fallopian tube, down through the endometrium, and then lodge into the cervix. Similarly, endometrial cancer, would those cells slough off and then lodge in the cervix, and then simply be gathered by a simple pap smear brush? We would take the DNA from that pap smear and then sequence it for these rare mutations. Now, I can tell you a lot of people thought we were crazy, including everyone who we try to get funding from. But when we finally did this study, we were surprised to show that we could detect 100% of endometrial tumors, even at the earliest stages, and about 40% of the ovarian cancers. Currently, there's no approved screening modality for these two cancers. And while ovarian cancer is known to be a huge killer, there's still 8,000 to 9,000 deaths every year from endometrial cancer. And it's much easier to treat these at stage 1A or 1B than it is when they're stage 4. And this is very promising to us. Obviously, everything I've talked about needs a lot of follow-up, but it's kind of turning the paradigm upside down. Rather than using these as prognostic or predictive biomarkers, can we use them as diagnostic tools to answer tough clinical questions? And I think that's really the challenge. The challenge is using this and applying it to tough clinical questions. If we look at so much of science, we correlate it with one interesting clinical phenotype. But once we apply it to a tough question, it kind of fades away. I think if we begin with a tough question, then the science can fill in the gaps. And I think that's what hopefully will happen here. But in summary, I think somatic mutations can be effective biomarkers largely because of specificity. We hear so much about the false positive rate of PSA or of mammograms or of so many other things. Mutations are very specific. If you have a KRAS mutation in your circulation, you probably have a precancerous or cancerous lesion in your body. It just takes that many cells to recognize that. Digital genomics has improved the sensitivity sufficient for real clinical application. Even 5, 10 years ago, this wasn't possible. The throughput with next-generation sequencing approaches, even digital PCR-based approaches, has really changed things where I think this is going to have an impact clinically. And finally, as I mentioned, I think future applications have to focus on unmet clinical needs. Monitoring patients and prognosis isn't enough. We need something that's going to change clinical management. Thank you.
So we're going to switch now from DNA analysis to RNA analysis. Professor Laura Vent-Veer is a professor of laboratory medicine and the Chan professor holds the Chan Endowed Chair in Cancer Research at UCSF. She's the leader of many breast cancer programs at UCSF. She's also a founder of Agendia, which brought you MammaPrint, which was one of the first FDA-approved multi-analyte tests. She's on the biomarker committee of the foundation at NIH and is a board member of AACR. Laura.
Thank you very much. It's a pleasure for me to sort of go over with you what is actually all happening in the world of RNA. And I focused actually merely on those RNA diagnostic tests that are in clinical use or really very close to clinical use. So my disclosure was already mentioned that I'm a co-founder and stockholder of Agendia. So just to refresh maybe for some of you your biology classes, RNA is in between DNA and protein, so it's really the messenger. How do we get all the genes in all our cells in the body to make an active protein that will eventually actually execute the function of that gene? So there are two different steps involved, but RNA actually also can give you a nice display of what the activity is of all the genes in a given tissue, either normal, of disease, or in many cases what I've been studying in cancer disease. So RNAs in that respect sort of sit somewhere in the whole middle. I took here another figure from the IOM Precision Medicine report, where you can see that the transcriptome, as it's sometimes called, so this is collectively all expressed genes, sits in the middle of all this information that's available on tissues. And it's actually the integration of all that knowledge will help to treat patients and also to help to identify targets for treatment and develop new drugs. So RNA transcriptome, although as part of this whole knowledge network, is already used in diagnostics in many ways. So how do we use this? And I'm not going over a list of tests, but people look in diagnostics laboratories at single gene expression level. Sometimes the expression of one gene can determine what type of cancer somebody has, whether this is a aggressive, invasive cancer or maybe a more benign disease, or is used to see whether there is a viral load or any other bacterial infection maybe instead of a cancer. And people look into fusion transcripts. Many cancers, the basis of cancer could be that chromosomes, genes of different chromosomes, fuse to one transcript, and you can understand that that puts a gene activity out of context and may contribute to the cancerous growth. So the way how to look at these single gene expression or fusion transcript is by a procedure called reverse transcriptase Pcr, which allows you to identify with high specificity again that particular transcript and then amplify so you can analyze it. This is a well-established technique, very robust and with a huge dynamic range, and many of the molecular diagnostics labs use this as part of their portfolio of diagnostic tests. RNA in situ hybridization is when you really look into the RNA when it's in the context of the cell, and I'll show you one example. Whereas for the first test, the RT-PCR first extracts the RNA out of the tissue and then does the assay. Gene signatures have been more recently been established where you look at a pattern of activity into one index, and that gene signature then foretells you what type of cancer, what activity, how aggressive the cancer is, and I'll show you an example in breast cancer. RNA sequencing, of course, like already mentioned, the DNA sequencing, also RNA sequencing, whole exome sequencing, targeted exome sequencing is becoming part of the portfolio of diagnostic laboratories. Some tests are maybe already used, others are more investigational, but there's a lot of promise, and I think it will deliver on its promise in the next near future. So these tests are actually used for disease state, prognosis and outcome, and prediction for therapy selection and efficacy. So one example, the DNA microarray technology, to look into activity of genes to the amount of RNA for each gene. So here you see one example where those little white shades that you see on the glass actually collectively represent up to like 40,000, 50,000 gene spots that each represent a fragment of a particular gene. And one can isolate the active genes from a tissue, give it a particular fluorescent color, and it will find its counterpart, its specific counterpart on this microarray. Here also, I think the robustness of this technology has really become to the level of diagnostic use. Why does it give an opportunity? Because here you're not looking into the activity of one particular gene, but you look at the activity of genes in the context. As you can see here, a single gene may show you activity, but only the bottom two panels show you the context of these two Andy Warhol pictures of either Marilyn Monroe or a flower bed. And this may mean something completely different if you look into a tumor tissue. So we use that particular technology to actually find a gene pattern of 70 genes that are expressed in breast cancer. And here in this picture on the left, you can see the different activity patterns above and below this yellow line, where green means a gene is not active and red it means it is. You can somewhat see that that's contrary to the top and the bottom. And on the right, you can see that with the white bars, this is indicative of whether a woman has developed a metastasis, in this case within a 5-year period. So we established this as a diagnostic marker, a diagnostic test, where above the yellow line resembles good signature and below poor signature. And each subsequent tumor that is analyzed today is still related to this original gene pattern and gives a result of good or poor signature or low risk of metastasis or high risk. So that the analysis, which is done by something called bioinformatics, really also makes sense is if you look into this particular picture, where here in the middle there is a tumor cell which has all the different hallmarks of a cancer cell. So a cancer cell needs to grow indefinitely, needs to invade surrounding tissue, needs to sustain its own blood supply. And not to go in any of the details, but those colored blocks represent all those different activities. And the little codes below are the codes for the different genes that are part of this 70 gene signature. And as you can see, they're represented in each of these hallmarks of cancer as first defined by Hanahan and Weinberg. So what does such a signature do? And I'm showing you here 2 examples, which is again the 70 gene MammaPrint, but also the Oncotype, another commercial test marketed by Genomic Health, where a gene pattern, in this case, not established on a microarray but by the combination of individual RT-PCR level measurements, you can see that if you are in a low risk or high risk status, or on the right side in low, intermediate, or high, that gives you a different outcome. If you see from left to right, patients who were diagnosed at day 0, and to the right you see their follow-up. Low risk does tremendously better than high risk. So how is this currently used in clinical practice? It's used for prognosis prediction and used as part of the adjuvant treatment advice. And so for low-risk patients, the risk might be so low that they can forgo chemotherapy, as well as actually that we started to see that low-risk patients do not actually respond to chemotherapy because of the biological nature of their tumor. So the clinical use of these 2 particular tests reduces chemotherapy overtreatment by up to 30%. And that's both of benefit for patients with less side effects, but actually also has an enormous economic benefit, because patients don't have to go through a year long of therapy, which many of them would take them out of the work process and therefore would give an economic deficit. One other way of measuring RNA activity is by looking within the cell, and here you can see a very nice picture of the cells where all these fluorescent parts are indicating that a particular gene transcript is present, as depicted here in this nice picture for messenger RNA 1 and messenger RNA 2, which in this case has two different colors, which you can visualize under the microscope. So this is used to see in what particular cells also a particular transcript is active and whether it is active. But sometimes the context of the tissue makes a difference to decide, for instance, on a particular treatment. So as one example, here is a in situ hybridization for the PD ligand 1 that you can see on the left in this sort of vague red color. I think you can see that on the slide. And the use, or the envisioned use, because this is in development, that such patients could be actually eligible for an inhibitor for this particular ligand that is present in their tumor cells. And there are more examples like this. So RNA assessment is part of the whole diagnostic portfolio. We've been discussing gene mutations so far, and these actually gives a very nice overview, again, of this hallmark of cancer picture by Hennehan and Weinberg, now updated for all the different therapeutic options that there are to, if, for instance, a cell is an indefinite in growing, one of the options is to test telomerase inhibitors. On the top, we discussed EGFR. So if there is a sustained proliferative signal, then EGFR inhibitors might be used. So RNA, for some of these, to assess whether that's a useful therapy, RNAs could be part of the portfolio. But it means that you need to actually have in a diagnostic laboratory many of these different tests, as one of the case studies showed before, that you need to do for one patient many of those. So in conclusion, many RT-PCR tests are in the standard of care. Prognostic profiles for breast cancer are in use. Therapeutic targets are tested in some settings, but some of these are still not fully disseminated, as we discussed before, sometimes hampered by complexity, availability of technology in all different hospitals. There's, of course, which we'll discuss later, the CLIA versus FDA versus guidelines controversy and different requirements for approval. And reimbursement is something that we'll discuss later today as well. So I hope I gave you an insight in where RNA diagnostics stands today. Thank you very much.
So lastly, we'll turn to proteins, and David Rim, who's a professor of pathology at Yale University. He got his MD and PhD from Johns Hopkins, continuing the Johns Hopkins theme of the morning. He's been interested in quantitative pathology in cancer using some novel techniques, and he's the author of many scientific papers and patents, and has also been involved with two companies, HistoRx and Metamark. Thank you very much, David.
So I'll start out with thanking my Hopkins classmate, Charles Sawyers, for inviting me to this meeting. And I would like to talk to you about something different, that is proteins. And I think that we've heard a lot about the DNA and the nucleic acid side, but the protein side sort of, I would argue, is extremely important and where the function is. That is, if you look at a caterpillar and a butterfly, they have the same genomics, but they have a very different function and very different profile. Caterpillars can't fly. And so I would keep that in mind as you consider proteins, but similarly, proteins have a lot of baggage. So I'll talk about measuring proteins, and proteins were actually the first companion diagnostic assay back when we did the ligand binding assay in the late 70s and early 80s. And then we'll talk about immunohistochemistry, which has been the way to measure proteins, and talk about baggage. Rarely believed by many non-pathologists. Any pathologists in the room? Okay, one or two, great. Unfortunately, the pathology portion of this will be hopefully educational for all of you. And then last, mass spectroscopy, which is another way of measuring proteins, which is gaining popularity, but also has been fraught with its own issues. So this is where it started. This was the first immunohistochemistry paper that showed that measuring estrogen receptor by eye, in the opinion of the subjective opinion of a pathologist, could be categorized into these groups. And when categorized into these groups, called the Allred score, by a group led by Craig Allred, you could see patients that did not respond or responded to tamoxifen. And this led to what is now the standard of care for every breast cancer patient, where they get estrogen receptor measured by the pathologist by eye. However, it shouldn't be that your pathologist determines your therapy if a different pathologist has a different therapy or results in a different therapy. In fact, your tumor should determine what ultimately your therapy is. And this is an example of a 100-case study with 3 different pathologists at different levels of training. And every case where you see in a circle is a case where, depending upon what their pathologist is, they got therapy or did not get therapy, as opposed to what their tumor was. That is, for example, in this case, over here, this pathologist 3 thought this was a Allred 0 or Allred 1, whereas pathologist 2 thought that it was a Allred 5, which means they would get estrogen or endocrine therapy. So this misclassification rate at about 10% represents as many as 20,000 patients a year, or perhaps more, given the other issues. So this is clearly a problem. This problem was addressed by a group led by Liz Hammond and assisted by Dan Hayes, who's in the room, trying to standardize this process and trying to make it so that we didn't have this subjectivity and try to shake the subjectivity out. But unfortunately, what they came up with 2 key criteria were the percentage of positive cells and any immunoreactivity. And any immunoreactivity was then became a judgment of the pathologist. Here's 2 spots stained in 2 different CLIA-certified labs. One, the one on the left here, is clearly positive. There are some little dark spots, and clearly you could find 1% of these nuclei that are positive. This is a serial section of the same case, stained in another CLIA lab. In this case, the patient would have been negative. This study was done comparing 4 CLIA labs. One was not a CLIA lab, so they were eliminated from the study, but you can see the discrepancies, and the discrepancies between these labs, ranging to as high as 32% between labs, were not the result of the percentage of nuclei positive, but rather, which you can see in the bottom graphs here, showing different levels from 0 to 100% positive and the levels of the discrepant cases, but rather the any immunoreactivity case or issue, because we can't reasonably standardize these tests between labs and because of the problems of immunohistochemistry. And in fact, you see in the discrepant cases, in fact, the reason this will never be published is that Lab 4 has a false negative rate of about 30%, and they were not willing to have this, this data formalized, and even though they would remain anonymous. So this is the situation, and this is the problem in immunohistochemistry and why we still have problems with it and why it probably hasn't gained acceptance as a reliable, reproducible diagnostic test. All of these patients would get trastuzumab, but these patients, even though they have a very different amount of HER2, would all be called a plus 3 in current pathology standards. And so these are the kinds of issues that we have to deal with. And the problem is people. Unfortunately, the human eye is not equipped to look and to be the measurement device for immunohistochemistry. If immunohistochemistry was measured quantitatively back in the 80s or 90s, or if there was a way to do that, I would predict that measuring protein might be much more popular. Here's an example of that for you all to try yourselves. Which square is darker, A or B? Well, clearly A looks darker than B, but that's because our perception and context. In fact, they're exact same color, they're same intensity, but we can't see that. And I brought a pathologist into my office once and showed them this, and they insisted that it was wrong, that I'd fooled them, so I had to add this part so that they could actually see that they are, in fact, the identical shade, and the human eye is just not the right tool for the job. So what is the right tool for the job? Well, we've worked for 10 years on using immunofluorescence, and this is a technology developed in my lab where instead of measuring or judging intensity, we measured strict fluorescence colocalization. And using this method, we created a concentration out of a numerator and a denominator, where the numerator is the intensity of estrogen receptor, and the denominator is the area of the nuclei in which the estrogen receptor is stained. That gives a reproducible standard that you can then standardize against Western blots, standardized against recombinant protein, standardized against cell lines, all to come up with an absolute cut point that can be reproduced in multiple labs in multiple settings. Its coefficient of variation is under 5%. How do we know that that's the right cut point? Well, we can actually go back and look at it. And even though these are the two cases in an index array that we tested that are right around that cut point, you can see that, well, actually you can't see, that one is darker than the other. And one is showing specific staining of the nuclei, the other is showing noise. So if I increase the gamma so that you can see it, now you can see that the first positive case is in fact clearly positive, but the last negative case in fact is just noise. And this is the kind of reproducibility we need when we measure proteins for patients in order to choose the right therapies and have high levels of reproducibility. It turns out that when you do that in that method, you can see that the positive cases, which are the cases that are in red here, are the discrepant cases, behave like truly positive cases read by any method. So how reproducible are these tests? So we've subsequently looked at reproducibility in 200 cases comparing pathologist to pathologist, a DAB quantitative analysis approach, which is the conventional brown stain, and then the quantitative fluorescence approaches. And you can see that by looking at the R-squareds, there's a fair bit of disagreement between the pathologists, even two pathologists, whereas two operators using automated tests do much better. Comparing the automated tests to each other, you can see that, and to the pathologist, you can see that the pathologist always tends to choose a high number. That is, we're just biased by eye to choose many cases being 100%, even though that isn't in fact the case. And in fact, when you compare the automated method, you see a problem as well with the DAB method, which tends to saturate compared to fluorescence. That's shown better in this figure, where you can see the saturation, of DAB on this axis and fluorescence on this axis, where there's actual lower dynamic range. The DAB dynamic range is about 1.5 logs, whereas the fluorescence dynamic range is about 2 logs. So this was our story, and a somewhat younger me in the left upper hand corner, which ultimately commercialized this technology back in 2004, which was subsequently bought by Genoptics in 2012, and which is the reason I didn't start with the disclosure. However, this has made it all the way from my lab into the clinical setting. Genoptics is a CLIA lab, and they offer ER, PR, HER2, and Ki67 using a quantitative immunofluorescence-based test. What's going to happen in the future, and is this the future for more accurate measurement of proteins? I hope so. This is a paper that came out from Michael Gertis and his group at GE, where they've multiplexed up to 50 different proteins using a quantitative fluorescent platform. I believe their platform is driven by the Definion software, which allows similar types of image analysis and colocalization to get similarly quantitative results. I can't speak to where they are in commercialization stage, but I think that this technology is very similar in terms of seeing the advantages of the dynamic range of fluorescence and the reproducibility of multiple assays. And lastly, I'd like to introduce what I think perhaps is the most promising new technology, which is MIBI, or multiplexed ion beam imaging. This isn't quite published yet, but I thank Mike Angelo and Gary Nolan in their lab for sharing this information with me. The idea here is that you take antibodies and tag them with lanthanide series elements, and then you actually take a mass spec and scan along the slide, and by mass spec collect up to 50 different elements tagged directly to 50 different antibodies, so that you can multiplex this up to 50-fold, but with the quantitative nature of measurement of lanthanide series elements in a mass spec. This has, I believe, tremendous potential, but the machine looks like this. So I don't think it's going to be in my lab anytime soon. However, I would anticipate that this technology will not only be used for discovery, but also be rescaled and commercialized in some more distant future time in a way that mass spec can be combined, and the accuracy of mass spec might be combined with the advantages of localization and the in situ nature of measurement of immunohistochemistry. As shown in this picture, you can see that they can quantitatively look at multiple different antibodies at the same time. It still suffers from some of the foibles of antibody measurement, that is pre-analytic variation, but the accuracy and the reproducibility are second to none. So finally, what is the next generation of measuring protein on slides? I think that we might see discovery on these sorts of mass spec and highly quantitative platforms like GE, or even less quantitative approaches to do the discovery. But ultimately, to get this into labs and to have it affect patients and to have it be in a lab that can withstand the rigors of CLIA certification, maybe not quite that complex a device is needed, or can be used by that many people. pathologists need to adopt this. Pathologists have been the slowest specialty to take up our fluorescence method. In fact, my invitations and my success has been much greater in the oncology community than in the pathology community, which is very hesitant to give up on their core competency, which is the reading part, the subjective judging. And even though they're really good at making diagnoses, I'm a pathologist, I think they're great people. But what we can do, we should do really well, and that is analyzing images and feature recognition and diagnostics, whereas when it becomes a molecular test, we have to be willing as a field to give that up, and I hope that that will happen, and we'll see pathologist adoption of automated microscopy with integrated standardization. And finally, will this happen in multiple labs, or is this the kind of thing that can only happen in a central lab, much in the way the sort of Oncotype DX tests sort of centralized so much of RT-PCR? I don't know the answer to that question. You can see here in the lower level a bunch of sort of small, compact, automated fluorescence microscopes, and perhaps this will be the next generation of fluorescence microscopy that goes into the pathology lab, or perhaps these will be done in centralized labs. But I believe that's where we are today. Thank you for your attention.
So DNA, RNA, protein, small instruments, very large instruments with unknown turnaround times. Questions from the audience about the variability and applications of these platforms as they come into clinical setting?
Everyone's hungry.
Yeah. Maybe we have a question coming here. Unless she's... No. Well,
Maybe I can take that as a question and,
yeah, exactly.
and tell you what the
Or
turnaround
comment
time
about
is
the
on the
panel,
mass
right?
spec.
Well, maybe I'll just ask one of the panel. So we heard about DNA methods, RNA methods, and protein methods. There's inherent variability in each one of those methods, and then there's the observer issues as well. How do we know when it's ready? And do we need, for instance, regulatory bodies to establish its readiness, or is the history of medicine that we're able to do that well enough ourselves?
I can take a first stab at the DNA one. I think one of the advantages that we're seeing on the DNA front is that the analysis of DNA alterations has moved from an analog analysis, which was Sanger sequencing, to a digital analysis, which is essentially multiple reads, digital of a particular locus or whole genome analysis. And that permits you, I think, in a very clear way to determine thresholds of error rates, thresholds of minimal sensitivity for bona fide mutations, and also the level of specificity. So I think although it's not easy and there are many confounding factors, there's repeated regions in the genome, there are artifacts that you get from different platforms, I think there are ways in order to standardize that for at the DNA level in order to resolve those issues. I think the bigger challenge is really knowing what to do with that information. So we really need, I think, perhaps not necessarily guidance, but we really need as a community to think about the challenges of how one interprets different levels of evidence in actionability of these different alterations, and recognize that when one says actionability, it really can mean a lot of different things at the DNA level.
You want to say something about RNA in that context?
I think it's I think if there are like low-level complexity tests, like a simple on the RNA aspect, a simple RT-PCR, I think there are standards to which you can compare the level of expression you're measuring in a tissue. So people are using standard measurements for that. I think if it comes to the more complex signatures, as you may know, my preference is to have an FDA oversight on that type of tests. And for next-gen sequencing, if it's RNA, I think if it's a single analyte, I think we can safely work under CLIA. If it becomes more complex, it needs to be, I think, evaluated what type of regulatory oversight that requires, but that might be FDA or there could be a combination of requirements to be developed by the different parties?
So in protein, we've been doing this for a while. It's called a coefficient of variation, and we measure it. So if you measure a CEA or a glucose, you measure the coefficient of variation, and you know the test is good. Unfortunately, that has not transferred over to anatomic pathology so well, and the FDA approval of estrogen receptor antibodies is based on the antibody, not on the test or the outcome. So that's probably not the right way to regulate that, although that's what's happened to date. And I hope to see that, I think it's clear that regulation is needed. The labs regulate themselves in some way. That is, CAP is the deemed status body that makes sure that the tests are reproducible and that they comply to standards. And we do this by the consensus between labs on tests. We don't have a defined standard, but rather use consensus as a standard, figuring if 200 labs get the same answer, it's probably the right answer. And so I think those are the kinds of things that need to be done. I would encourage, as people think about this, to think about coefficients of variation beyond just protein testing, but rather what is the coefficient of variation of next-gen sequencing on any given base pair? And I don't know if there's an answer to that question.
We have time for one question,
Yes,
I
so I'm
think.
going to direct this at Dr. Diaz. You gave a pretty compelling case for trying to use body fluids for diagnostics, and you showed some pretty good sensitivity data, but not specificity data. And I guess a lot of us have always worried that you would have a lot of false positives with this technology because, don't we all have, some benign polyps growing in our bodies, and all our nevi are BRAF V600E. And so is that a greater concern than reality, or what really is the threshold for overdiagnosis or the potential for overdiagnosis with this technology?
Yeah, I think that's a great question. There's the technical specificity of the assay, and then there's the biologic specificity. And I'll start with the biologic one because that's easier in a way. To detect, let's say, a solitary mutation from a tumor, what we've seen when we track back to CT scans and actually even looking at patients who've undergone autopsy post-resection or post-mortem autopsies when we've drawn blood, is that about 1 billion cells are required for 1 fragment of DNA per mil. Now, that doesn't necessarily speak to your specificity question from a technical standpoint, but it does tell you that things smaller than 1 centimeter, you're probably not going to detect. You need a clonal population to detect something real. Now, you can have clonal populations that are benign, adenomas. You can have benign nevi, like you were mentioning, that are fairly large, that have mutations in BRAF or even in TERT, and those we detect in circulation. So I think as we learn more about the genetics, and as we can assay more than 1 mutation and multiple mutations, we'll be able to figure out whether this is a solitary genomic event leading to a benign lesion or one that's more complex. And what I didn't show is that you can measure things like aneuploidy, you can measure things like structural alterations. And again, as we understand the biology more, and hopefully with more work from genomic sequencing, we can understand those pathways. Now, the technical specificity is a big issue. Will you generate false positives just through the handling of the sample from ambient false positives in the DNA in the area, from the PCR reaction that you do to amplify the region of interest from the next generation machine? And as we move towards high throughput methodologies, our specificity in larger groups and biological samples is in the high 90s, but it's certainly not perfect yet. And that speaks to more of the technical limitations than the biological limitations.
So platforms matter. The way you measure things is important. And have a good lunch.
Not much.